So if this was a normal prostate, we might say this is a well-differentiated adenocarcinoma, this is a moderate or moderately well, and this is a poor. And if we wanted to put that in a pathology report, we might actually use the descriptive language going from the best differentiated degree of differentiation, which is called well, to the least best or the worst differentiated or the worst prognosis, in which the word poorly differentiated might be applied. Sometimes grading, especially in the older days, was given numbers or Roman numerals or letters, most likely numbers. And except for prostate, this numeric system doesn't seem to be too important anymore. In prostate, these numbers called Gleason's numbers are extremely important, though. Now, in terms of staging, the predominant staging system universally in the world and for most organ systems is the TNM, with T representing the degree of involvement or size of the tumor, N representing regional or other lymph node involvement, and M being metastatic. So, for example, a T1 tumor would be smaller or better prognosis than a T3 or a T4. Sometimes these numbers go up to 3 or 4. I've even seen them higher. Sometimes you'll see the term IS after a T, referring to the fact that the malignancy is in situ. Sometimes you'll see the subscript X after an N or an M, referring to the fact that the degree of node or metastatic spread is not assessed or unknown. Sometimes, especially with lymphomas, the staging is in terms of Roman numerals from 1 generally to 4. It doesn't go much higher than that. Sometimes it goes to 3. And once again, with grading, sometimes you'll see regular letters or numbers, but that's not used too much anymore. And pretty much TNM has become the gold standard in all of its variations. We diagnose cancers by biopsying them, looking at them, or perhaps scraping gently the cells from them like in a pap smear, or sticking a needle into the tumor and looking at the aspirate of that. And generally, the fine needle aspirate has like mushroomed over the past generation or so in terms of utility and convenience and diagnostic accuracy. But generally, these are the common ways. Another thing that has mushroomed over the last generation or two has been the concept of immunohistochemistry. And to make a long story short, immunohistochemistry or immunochemistry or immunoperoxidase, which it was called in the old days, is basically a way to stain antigens on tumor cells. That's all that it is. So if you have a very undifferentiated tumor and you don't even know whether it's a sarcoma or carcinoma, for example, you might want to stain it with classical epithelial or stromal markers to find out where it came from. Sometimes you could actually figure out what organ it came from too. Often you can't. Not all organs have specific antigens. Also, immunochemistry is used extensively in the classification of leukemias and lymphomas. And the things that are stained are often called markers as well. Sometimes, if you want to know whether a tumor will be responsive to estrogen or progesterone, you can do immunohistochemistry to find out whether that tumor is ERA positive or estrogen receptor positive or PR positive. So these are the 4 common reasons for using immunohistochemistry, which is very, very much welcome diagnostically, medical legally, but usually not needed to be done in straightforward tumors. And speaking of tumor markers, let's introduce the concept that certain tumors, once again, express certain compounds. We saw in the case of hormones, tumors are expressing endocrine compounds. Some tumors express antigens which are called oncofetal, and that might be seen with, for example, a CEA or an AFP from a GI or a liver cancer. AFP standing for alpha fetoprotein, CEA standing for carcinoembryonic antigen. Sometimes the tumor markers are isoenzymes like PAP or prostatic acid phosphatase. You could guess that this would be from a prostate tumor, or NSE, neuron-specific enolase. You might expect that this isoenzyme might be from a neural type tumor, like a neuroendocrine tumor, like a small cell carcinoma. Certain proteins like PSA, prostate-specific antigen, can be expressed by tumors. Certain glycoproteins like CA125, notoriously with ovarian cancer, other CA glycoproteins as well. And of course, some of the tumor markers can actually be the measurement of the proteins that are coded for by the specific oncogene. So we can measure the p53 gene or the p53 protein, and the same with RAS as well. Now, the most important to remember, however, is that these tumors may express these substances where they can actually be measured in the blood, but they may not be in high enough quantities to be measured in the blood. So often you would have to take these tumors and stain for these specific things by looking at the tissue itself. So just because a tissue, for example, might be positive for PSA, that doesn't mean that it's going to be as high enough to have blood levels. And also remember another thing, most or many of these things are not perfectly specific for tumors. They're often expressed by the normal tissue itself, so hardly any of these things would be recommended as screening tests. But what they are very, very valuable for is to look at the follow-up of a therapy. For example, if somebody has had prostate cancer and their PSA levels has been low after surgery, after radiation, after chemo, and all of a sudden there's a significant increase or rise, then that might be an indication that the tumor has recurred, even if there is no other anatomic evidence by the usual diagnostic or radiologic modalities. And last but not least, it wouldn't be fair if we didn't talk a little bit about microarrays. And I'll have to admit that I am pretty ignorant on this technology. I had to do a lot of reading about it. And it's been said that in the future, tumors will be diagnosed not under a microscope looking at cells, but by taking those tumors and putting them onto these little microchips, which have many thousands of gene fragments on them in different tiny areas, or oligonucleotides, and then to see what specific genes are expressed or not expressed. Well, the people who say that the pathologists aren't going to have any microscopes anymore are usually the people that never spent their life devoting their lives to the art of being able to recognize things under the microscope. But there's no doubt that in the future microarrays will be very, very good for both diagnosis as well as a treatment. Right now it's in its infancy stage. Probably by the time you're teaching pathology, it may very well replace much of what we do in microscopy. And this is the end of the single biggest chapter for general pathology, the chapter on neoplasia. And, like Sarah Palin, I felt like I basically survived it, and I learned a lot of new things. I wish I really, really, really knew a lot more about it. I don't feel like I conquered this chapter. I felt like I adequately presented it in a decaffeinated kind of way, but that's really for you to decide. So once again, I thank you very much.